start कर दी. So, benzodiazepine, the use and abuse and myths and the misconceptions related to benzodiazepine. This is a very strange topic, unfortunately, because हम बेंजोडाइजेपिन्स हमारी प्रैक्टिस का पार्ट एंड पार्सल है और उसके बगैर हम साइकियाट्रिक पेशेंट्स देख नहीं पाते. और क्योंकि हम साइकियाट्रिक पेशेंट्स बेंजोडाइजेपिन पे बगैर देख नहीं सकते, तो इसलिए ये इंपॉर्टेंट एरिया है. Generally speaking, people say that benzodiazepines should not be prescribed. They should not be prescribed because they have certain limitations, which we will talk about very shortly. But without benzodiazepines, we are stuck up. Psychiatrists, I think if you look at the prescription of the psychiatrist, they use the minimum possible benzodiazepines. However, if you look at the prescriptions of other physicians who are treating the anxiety disorders, benzodiazepines are their first line of treatment. अब जब सारे दूसरे लोग बेंजोडाइजेपिन्स लिख रहे हैं, तो बेंजोडाइजेपिन्स फिर हम साइकियाट्रिस्ट ही क्यों बदनाम हैं कि जी हम नींद आवर गोलियां ज्यादा देते हैं. ऑल्दो कि अगर आप जनरली साइकियाट्रिस्ट का प्रिस्क्रिप्शन देखें तो बेंजोडाइजेपिन्स शायद सबसे कम एंजाइटी डिसऑर्डर्स के लिए या बाकी डिसऑर्डर्स के लिए साइकियाट्रिस्ट लिखते हैं. So this was another idea why I felt that this is necessary to know that are we really doing the right thing, or it's just a misconception that psychiatrists write more benzodiazepines. We do not. As knowledge about the biology of normal and abnormal brain function continues to grow, the practice of clinical pharmacology continues to evolve in scope and effectiveness. And we all know that. Back in historically in mid 1950s, so आज से कोई 70 साल पहले, Roche Labs synthesized two compounds appeared to be superior to meprobamate and chlorpromazine, right? So meprobamate and chlorpromazine are the oldest antipsychotic medications available. And at that time, they felt that there is something more required to address other issues in psychiatric practice. The work of Leo Sternbach and Earl Reeder led to the development of first benzodiazepine, which is chlordiazepoxide in 1959. So the first benzodiazepine which was launched was chlordiazepoxide. There are now 36 benzodiazepines in the market. Surprisingly, some of the benzodiazepines are now not available in Pakistan, which unfortunately creates further complications, especially the long-acting benzodiazepines. So I expect all of you to do two things. One, make sure that you know and remember the half-life of all the benzodiazepines, not only which are used in psychiatry, but otherwise जो market में available हैं या जो market में available नहीं हैं, सबकी half-life as a psychiatric resident, you should know that. So if you are prescribing a risperidone or olanzapine or Valium or clonazepam or any drug, you should know the half-life. The reason why I'm focusing on the half-life is that when we know the half-life, we know how to distribute the daily consumption of a benzodiazepine. So if you're writing diazepam to a patient, it can be given once a day because the half-life is more than 72 hours per tablet. And it has a cumulative effect as well. So एक गोली अगर आज खाइए और एक गोली कल खाइए और एक गोली परसों खाइए, तो practically patient 30 milligrams of Valium पे चला गया, which is tricky. Same goes for, unfortunately, clonazepam as well. The half-life of clonazepam, as mentioned in some of the books, is more than 100 hours, plus minus. So cumulative effect means कि जब आप एक बेंजोडाइजेपिन देते हैं और अगले दिन उसकी दूसरी डोज जाती है और उससे अगले दिन तीसरी डोज जाती है, तो वो प्रैक्टिकली आप एक हाई लेवल पे चले जाते हैं विदाउट नोइंग इट. So if you prescribe alprazolam, it's a short acting or a moderate acting benzodiazepine, its half-life is less than 24 hours. You have to give it in a split dosage and it won't be having a cumulative effect. But if you are giving a diazepam, which is a long half-life, it will have a cumulative effect. So you should remember that when you are giving diazepam or clonazepam or long-acting benzodiazepine, any one of them, then taking it twice a day never means that initially that you have given just say 4 milligrams of clonazepam. It will be actually next day it will be 8 and by third day it will be 12. So 12 milligrams of benzodiazepine will be consumed because it has a cumulative effect, it has a long half-life, it stays in the body, and the previous dosage was already there and the new dosage was added into it, so it multiplied, right? So this is the basic thing that you have to remember. So the half-life for all the benzodiazepines, for you to know about it, is the most important thing that you should consider. ये एक शेर है, बात सीरत की है, असर की है, दिखावे की नहीं, दिखने में तो तेजाब भी है पानी जैसा. So benzodiazepines unfortunately are considered to be the bad drugs. Actually, देखने में तो तेजाब भी है पानी जैसा. So benzodiazepines को अगर हम consideration में रखें, this is the key. Now, all benzodiazepines are not alike. Rather, each has a distinct, different side effect profile. Benzodiazepines are divided into long-acting and short-acting. Now, there is a third group in it, which is called moderate-acting. So some books quote it into 3 different types: short-acting, moderate-acting, long-acting. And most of the books, they divide them into short-acting and long-acting. Now, there are some benzodiazepines which are ultra short acting as well, if you want to really divide into further categorization. So, like one benzodiazepine which was withdrawn from the market was called Halcyon. Now, Halcyon was a kind of a drug which was unfortunately withdrawn very quickly because of the fact that it was having ultra short acting half-life. So maybe few hours, 2 to 4 hours, the half-life was there. The good part was that it washed out from the system very quickly. But the bad part was that being a very potent hypnotic agent, it was actually giving lots of problems to the patient, so it was withdrawn. So potency of a benzodiazepine is dependent on mostly the dosage regime, the half-life, and its steady state achieved. So some of the benzodiazepines, like lorazepam, is considered to be a short-acting. Actually, its half-life is around 12 to 14 hours, maybe more than that. I don't remember it precisely, but it has to be given at least once or twice a day. It cannot be given only once a day if it is given for any therapeutic reasons. The other benzodiazepines, unfortunately, again, long-acting benzodiazepines and short-acting benzodiazepines, some of them are available in Pakistan and some of them are not. Talking about bromazepam. Now, bromazepam is a drug which is a benzodiazepine prescribed a lot in Pakistan, and it's not available anywhere otherwise. So maybe it was available in the past in these countries, but now you cannot find bromazepam in Canada and America. You can find bromazepam only in Pakistan and associated other countries around it. Why is it so? I don't know the reason. But of course, there might be some legislative rules. Some pharmaceutical companies have their own priorities and policies. So that might be the reason why it was withdrawn. So it's complicated. So you have to be careful about what you are doing. Now, as we know that when we talk about disorders, anxiety disorders, so PTSD, panic disorder, GAD, OCD, social anxiety disorders, and MDD, all of these disorders, we have to use a benzodiazepines in the short period of time till the time the regular dosage of an SSRI or SNRI starts its functioning. So that when I write a prescription, the people who work with me, they know that we write an SSRI, we give a benzodiazepine for 3 to 4 weeks time, We give it in a tapering off plan, and then gradually it is withdrawn when the SSRI effect comes in. This is an ideal situation, that you combine a benzodiazepine and the main drug SSRI. I'm not in favor of giving an antipsychotic in low dosage with an SSRI because it creates further complications in number of things. So we can talk about that too, why it is not. So some people use low dose of antipsychotic with an SSRI to induce the sleep or to induce the relaxing effect, which unfortunately maybe in short period of time is helpful, but in longer period of time it can complicate the situation. Maybe we won't be getting the precise therapeutic effect. So if we go through the guidelines, whatsoever you want to follow the guidelines, the NICE guidelines, the Musleh prescribing guidelines, they all vary in a short period of time, but longer term, they always say that benzodiazepines should not be prescribed for more than 6 weeks because of their potency of dependence and addiction. So that is unfortunately tricky. Now, indications in psychiatry for a benzodiazepines, and again, this is very much there: panic disorder, OCD, dissociative disorders, somatization disorders, substance use disorders, psychosis, all forms, depression, all forms, personality disorder. These are all the indications where we use benzodiazepine. But again, we have to make sure that we are not primarily using a benzodiazepine as a treatment strategy, but as a supporting strategy so that it can be withdrawn after some period of time. अब लोग कहते हैं जी बेंजोडाइजेपिन बिल्कुल ना लिखें, सो अगर वो बिल्कुल नहीं लिखेंगे तो हम the prognosis and outcome of most of these disorders will be difficult, because if we prescribe an antipsychotic, say I write aripiprazole to a patient who's having schizophrenia. Now, if I start aripiprazole in low dosage, patient won't have the calming down effect soon, because aripiprazole will take about 3 to 6 weeks before it settles down in the system and have a therapeutic effect. During that time, if I won't prescribe something to get an immediate relief, I'll be stuck. So I have to prescribe a benzodiazepine along with aripiprazole. Benzodiazepine will be withdrawn and the antipsychotic will be continued, which will have a therapeutic effect later on. The medical indications of benzodiazepine are more interesting. So I prescribe benzodiazepine for spastic disorders. So if somebody is having, say, cerebral palsy, children, they need benzodiazepine as a muscle relaxant. If somebody is having some other problems related to spastic disorders, we have to prescribe benzodiazepine not as a sedative, but we are using it as a muscle relaxant because it's a good muscle relaxant. It controls and withdraws the person from that pain and agony in the short period of time. Of course, we have to see the risk and the benefits of using it in the long term. So there are patients who may need a benzodiazepine for a longer period of time than what we expect it to be in spastic disorders. Palsies, trauma, pain, diagnostic and surgical interventions. So if I'm going for a surgery, I will be anxious and I need something as a support for a few days so that I'm prepared for the surgery appropriately. On one hand, this is the strategy. On the other hand, benzodiazepine will impair my cognition and maybe will create some problems. Same goes for the exam situation. Just giving you an example. People use benzodiazepine in exams to make sure that they sleep properly and they are relaxed. Unfortunately, they are counterproductive because benzodiazepines hamper the process of learning and memory reconsolidation. So whatever you are learning, if you are on a benzodiazepine, you will tend to forget it and won't be a part of your long-term memory. And in exam, the process is such a complicated one that when you want to retrieve something which you try to remember or memorize, the benzodiazepine will hamper it. So we cannot prescribe benzodiazepine to a person in an exam situation. But for detoxification, if a person is in pain and agony and withdrawal, we need something to calm him down urgently, and we need a benzodiazepine. Same goes for the movement disorders. We see people with lots of movement disorders. So tics होते हैं, stereotypic movements होती हैं, mannerisms होते हैं, और movement disorders हैं like extrapyramidal side effects हैं drugs के. कुछ situation में, unfortunately, the problem is that the procyclidine or other drugs, anticholinergic drugs that you want to administer along with the antipsychotic to control the movement disorder is not the solution. So things do get complicated. And there you need a benzodiazepine to make sure that the person overcomes the movement disorder as well. Epilepsy. Now, clobazam and clonazepam are considered to be and the diazepam, one of the primary drugs in epileptic phenomena where it is not controlled immediately. So if we want to make sure that the person won't have a seizure, so one seizure was in the morning and one in the afternoon, we want to make sure that he won't have again a seizure in the evening. There is no anticonvulsant which can do that suddenly. They all take time to establish the serum levels, steady state, and then the sodium, potassium, the gated channels, and all that stuff that needs time. So we need something urgent, and clobazam, clonazepam, or the diazepam are the solution. Previously, before prescribing benzodiazepine, we were using barbiturates. Now, barbiturates, unfortunately, were used for more than 120 years. But barbiturates have their own problems. So what should we choose? It's a lesser evil or more evil or whatever. Now, declaring it that this benzodiazepine is actually a bad thing won't solve the problem. It is actually the right prescription at the right period of time for the right amount of time for the right dosage, which matters the most, right? Anxiety associated with general medical condition or amnestic syndrome, all of them, they require the benzodiazepine. So we have psychiatric indications, we have medical indications. Clinical use, the first and foremost thing, I hope you are all with me. Benzodiazepines clinical use have a rapid onset of therapeutic action and generally produce almost immediate effects. So you try to take half a tablet of midazolam, which is a short-acting benzodiazepine, and you sleep within half an hour, which is an immediate effect. So if you really want the person to be sedated soon, you give an intravenous midazolam diluted in normal saline, and patient will be sedated. Even for dissociative situations where you want to give, what do you call that? Again, the name is skipping in my mind. So you need a benzodiazepine. Are commonly prescribed for short-term, intermittent, as-needed use in the treatment of anxiety and sleep disorders. Also used as sedatives before some surgical and medical procedures, and used for the treatment of seizure disorders and alcohol withdrawal. So if somebody is having an alcohol withdrawal, there is no other drug than the benzodiazepine which can have an immediate good effect. So कहने की बात ये है कि benzodiazepines are essential medications in psychiatry and medical situations where unfortunately we need immediate desirable effects. It's the appropriate use of a benzodiazepines. Now, how many of you have given intravenous midazolam to calm down a patient or to sedate a patient? Any one of you who has given midazolam intravenous? Anyone?
इंट्रामस्कुलर ही दी थी मेरा ख्याल है.
अब इंट्रामस्कुलर मिडाजोलैम जो है वो यूजुअली हम इंट्रामस्कुलर कोई बेंजोडाइजेपिन, क्योंकि बेंजोडाइजेपिन अगर हम इंट्रामस्कुलर देंगे तो उसकी एब्जॉर्प्शन अनप्रेडिक्टेबल होगी. हो सकता है उसको इमीडिएट रिलीफ ना मिले और 4 घंटे बाद वो ऐसा सोए कि वो उसको रेस्पिरेटरी डिप्रेशन हो जाए. सो इंट्रामस्कुलर benzodiazepines are usually not recommended. They are recommended in certain situations, but usually no. So intravenous midazolam is a miracle drug if it is given in an appropriate dosage and appropriately intravenously. आप midazolam लें, उसका इंजेक्टेबल लें, उसको डाइल्यूट करें, उसको स्लोली इंजेक्ट करें, रेस्पिरेटरी रेट और हार्ट रेट पर नजर रखें और पेशेंट विद इन सेकेंड्स सो जाता है. एनेस्थेटिक्स इसको इस्तेमाल करते हैं.
Yes sir, post op anesthesia के patients में दी हुई है मैंने services में.
बिल्कुल. So you see these people do use it, but अब उसको लेबल कर दें कि जी ये this drug is not appropriate, then where will we go? We will end up nowhere. So we have to use it precisely in a therapeutic dose appropriately to have a good effect. And intravenous midazolam, honestly speaking, is a miracle sometimes. So some of the people, they respond to it so quickly that their symptoms are relieved immediately. They feel relaxed, comfortable, calm, agitation, aggression, everything settles down within minutes, right? So now ligands of the benzodiazepine receptors, GABA and benzodiazepines, reducing chloride channel opening, anxiolytic, sedating, and anticonvulsant properties. And benzodiazepines are used commonly. Increasing chloride channel openings produces anxiety and induces seizures and some beta carbolines. Benzodiazepine antagonist, no activity of themselves, flumazanil. How many of you know about this drug? Flumazanil. और कभी किसी ने दी?
सर सुना ही है इसके बारे में, कभी दी तो नहीं ऐसे प्रेजेंटेशन.
अब इसको देने का एक खास तरीका होता है, राइट? ये लाइट सेंसिटिव मेडिकेशन है. So it comes in a vial which is covered with the aluminum foil so that light का exposure ना हो. Intravenous आप देते हैं, खास तरीके से देते हैं, डोज मेजर करके देते हैं. अगर आप देंगे किसी शख्स को भी बेंजोडाइजेपिन की टॉक्सिसिटी डेवलप हो रही है, flumazanil immediately displaces the benzodiazepine from the receptor sites and the person is absolutely conscious within seconds. Now, this is unfortunate that we are not practicing. So none of the psychiatric residents have the exposure of the flumazanil. Well, I usually try, even in some of the cases, I will say that it is not required, but I try कि जहाँ पे indication नजर आए, flumazanil psychiatric resident को देना चाहिए ताकि उसको पता चले कि flumazanil देने से benzodiazepine की activity में क्या हुआ. And it is important. So all of you, if you people are psychiatric residents, which I believe most of you are, you should try to give flumazanil. It's expensive. It's given in emergency situations. It is given in a specific situation. कैसे देते हैं, किस तरह देते हैं, कितनी डोज देते हैं, उसके बारे में हम कभी बात करेंगे. But try it. It's a good antagonist of a benzodiazepine. So benzodiazepine limitations and drawbacks. When used chronically, benzodiazepines can be dependence producing. Now, the word is can be dependence producing. अब dependence की एक definition है. जब आप definition dependence की demarcate करते हैं, तो एक अगर तमाम वो drugs जो withdrawal symptoms produce करें, वो dependence के जुमरे में आ जाती हैं. तमाम वो drugs जिनको खाने से dose escalation करनी पड़े, वो dependence में आ जाती है. So heroin ले लें, बाकी चीजें ले लें, gradually same desired effect हासिल करने के लिए आप उसकी डोज को बढ़ाते चले जाते हैं. I have seen people who've been taking Ativan on their own for 40 years. कि वो जी आधी गोली या एक गोली मैं रोज की खाता हूं और मैं ठीक हूं. अब एक शख्स अगर 30 साल से एक गोली रोज की खा रहा है, ना उसने डोज बढ़ाई, ना उससे उसको चस लेने की आदत है, ना उसको उसका मजा आता है, लेकिन वो उसके बगैर सो नहीं पाता, then why should I discontinue it or stop it if he's not developing any side effect? So that is a clinical judgment and clinical call for me what to do about it. So अगेन डिस्क्राइबिंग इट, ओह तबाही फेर दी, 40 साल से आप एटीवैन की गोली खा रहे हैं। वेल यस, पहला रिस्पॉन्स मेरा भी मरीज को यही होता है, मैं यही कहता हूँ बात जी 40 साल से आप गा रहे हैं, आपने किसी से मशवरा नहीं किया, आपने किसी से बात नहीं की, क्यों नहीं छोड़ा इसको, ये तो इलाज नहीं है, फाइन, बट when I'll be going for the treatment, I will never stop it suddenly. I will never do it. I maybe if needed, I can taper it off. और इसका भी एक फॉर्मूला है, वो बड़ा सिंपल सा फॉर्मूला है, और वो फॉर्मूला अनफॉर्चुनेटली मैं यहाँ नहीं लिख सका क्योंकि ये पुरानी प्रेजेंटेशन है, लेकिन उसमें जितनी अमाउंट है बेंजोडाइजेपिन्स की, जितने महीनों से वो सालों से दिनों से खा रहा है, वो नंबर ऑफ डेज इनटू हाफ लाइफ डिवाइडेड बाय हाफ लाइफ, नंबर ऑफ डेज यू टेपर इट ऑफ। सो अगर सपोजली एक दवाई की गोली वो 1 मिलीग्राम की खा रहा है जिसकी हाफ लाइफ 12 घंटे है और वो पिछले 1 साल से खा रहा है, सो 365 दिनों से खा रहा है, तो उस डोजेज को हाफ लाइफ से डिवाइड करके मैं नंबर ऑफ डेज में वो टेपर ऑफ करूंगा। सो मे बी कि मैं उसको 6 हफ्ते बाद क्रॉस करूंगा। सॉरी, somebody was saying something? No. Okay. Then I should continue. Okay. So this formula, you will find it in the books, and the precise formula, I will try to give it to you as well. It's not an unusual thing, but when you have to withdraw benzodiazepine, there's a specific formula for it. You have to apply that formula, only then you will know the precise number of the days on the basis of which you have to withdraw a benzodiazepine. You cannot shut it down. You cannot do anything straight away. Otherwise, पेशेंट ठीक करने के बजाय आप और खराब कर देंगे। और हमारा मकसद पेशेंट को खराब करना नहीं है, हमारा मकसद पेशेंट को हेल्प करना है, उसको बेहतर एजुकेशन देना है, उसको सेफ्टी देनी है, उसको लॉन्ग टर्म कॉन्सिक्वेंसेस बताने और फिर प्लान बनाना है। और मैं सिर्फ इसलिए कि 40 साल से आप एटीवैन की गोली खा रहे हैं, मैं इसको बंद करा दूं, I will be doing a very bad thing to the patient. So I cannot do it. Anything wrong with my patients. I have to be empathetic with them. I will explain it to them, and then I will make some plan. Maybe कुछ थोड़ा सा डरा भी दूं उनको, लेकिन I have to be very systematic if I really want to withdraw a benzodiazepine. This is important for you, all of you, to understand. In addition, they have no effects on depression, which is often comorbid with anxiety disorders as well. So, आमतौर पे फिजिशियंस दवाई दे देते हैं बेंजोडाइजेपिन्स इस चक्कर में कि जी डिप्रेशन को ट्रीट करेगी, डिप्रेशन का तो इफेक्ट कोई आएगा ही नहीं। बेंजोडाइजेपिन एंजाइटी डिसऑर्डर्स में मेजॉरिटी को वक्ती तौर पे सप्रेस कर देंगे, जस्ट लाइक पुटिंग अ लिड on something which is bubbling up, but it won't be a cure. It will be just a short-term situation. थोड़ा सा ब्रेक लेके, ये एक छोटी सी तो खैर नहीं, अच्छी खासी बड़ी गजल है, लेकिन मैं सुनाऊंगा जरूर आज। मेरे हम नफस, तेरी कैफियत मेरे हम नफस, कभी आग है कभी आब है, तेरे इख्तियार में कुछ नहीं, ये मोहब्बतों का अजाब है। जरा ठहर जा, जरा सोच ले, मैं तेरा हुआ कि नहीं हुआ, तेरी आगही के करीब ही तेरी वहशतों का सराब है। दिल बे अमा को अमा मिली, तू मिली तो मुझको गुमा मिली, जहां तूने मांगा था दिया, मेरे सीना खाना खिजाब है। ये शेर मुझे सही नहीं आ रहा। वही है बेकली, वही है बेबसी, वही बंदिशें, वही चाहतें, मैं अभी तलक ना समझ सका, तू नसीब है कि निसाब है। कोई एक खालिद नहीं यहाँ जो तड़प रहा है निहा निहा, राह इश्क आशिकी के जहां में सभी सूरतों पे नकाब है। अनफॉर्चुनेटली अगेन व्हाई आई कोट इट स्पेसिफिकली, वही बेकली, वही बेबसी, वही बंदिशें, वही चाहतें, मैं अभी तलक ना समझ सका, तू नसीब है कि निसाब है। और मैं इसको रिलेट करता हूं अपने पेशेंट्स के साथ, और मैं ये सोचता हूं कि जब मैं एम्पथाइज कर रहा हूं अपने मरीजों के साथ, तो मैं उसको क्या बताऊं कि तेरे नसीब में डिप्रेशन और एंजाइटी लिखी हुई है, क्योंकि ये जेनेटिकली बेस्ड है, कि ये निसाब है जो उसको पढ़ना है, तैयारी करनी है और ठीक होना है। Sometimes it's very tricky in psychiatry. Same goes for the benzodiazepine again. If we think that every patient using benzodiazepine will have an abusive tendencies, I think no. We have to understand the intensity and the severity of the situation before we intervene. कह देना बड़ा आसान है, छोड़ दो, ठीक है? अगर इस तरह छोड़ सकते होते तो हम सब दुनिया जहान की बुरी आदतें छोड़ देते, ठीक है? हम लाहौर में रेस्टोरेंटों में खाना खाना छोड़ देते। कौन नहीं जानता पिछले दिनों कितने फसाद बरपा हुए, गधों का गोश्त बिक रहा है, उसके बावजूद we cannot stop it. So if we cannot stop this one habit, how do we expect our patients to stop using benzodiazepine suddenly because I want them to? That's tricky, unfortunately. So understand this. Before you people make a firm decision about it, please understand the situation. Only then implement it. Sedation. I have seen people using 10 milligrams of clonazepam, no sedation. One of my patients, long term, he was not directly my patient, but indirectly a patient of mine. He was abusing 40 to 70 tablets of bromazepam every day. ठीक है? I have seen myself कि वो pharmaceutical store से निकलता था पत्ते लेके और वो पत्ते खोलता था गाड़ी में और 60-70 गोलियां एक वक्त में खाता था पानी के साथ और फिर आराम से ड्राइव करके घर चला जाता था. So is the sedation really a problem? Not in every case. It is directly proportional to my arousal level. If my arousal level is too high, I need a stronger dose of a benzodiazepine. And if my arousal level is too low, I will need a small benzodiazepine. So कुछ लोग आधी गोली खा के ब्रोमाज़ेपैम की 18 से 24 घंटे सो जाते हैं, ठीक है? क्योंकि उनको एंजाइटी नहीं होती, उनका अराउजल लेवल बहुत धीमा और नीचे होता है. और कुछ लोग 70 गोलियां भी खा के सेडेशन अचीव नहीं करते. So it varies how your brain is functioning. How much is the arousal level in the brain? And unless or until we'll understand that, we won't be able to understand this phenomena. Why this person having one benzodiazepine is sleeping for 24 hours and the other person having hordes of benzodiazepine is not sleeping at all. It all depends on the, unfortunately, this is small thing inside this khopadi. Tolerance. As I told you, tolerance. Development of tolerance means that to achieve the same desired effect of euphoria or sedation or anything calming down, we have to increase the dosage with every passing day. And as I told you, I have seen people who take one tablet for years and years and they are not developing the tolerance. Now, there are other definitions of the tolerance as well, which probably maybe they will be fulfilling, but not this one. Ataxia. If you are drowsy, if you are sedated, if you are having as an hypnotic, you may have ataxia, otherwise you won't develop ataxia. Cognitive impairment. अब इस पे बहुत ज़्यादा बहस है. Now, benzodiazepines never impair your memory, which is already there. They can mask it, but they won't impair it. But the benzodiazepine will do the anterograde amnesia. Anterograde amnesia is कि जब गोली खाई उसके बाद के जो इवेंट्स थे वो भूल गए, उससे पहले वाले इवेंट्स पे कोई इफेक्ट नहीं आया. Right? So concentration and memory of the new materials is compromised, not the old ones. जो माजी के ट्रॉमेटिक इवेंट्स उसके दिमाग में चल रहे हैं पीटीएसडी में या किसी भी डिसऑर्डर में, वो नहीं जाएंगे. सिर्फ वहां से जहां से दवाई खाई आगे वाली चीजें रजिस्टर होना बंद हो जाएंगी. So this is a complication and you have to understand that as well. When you are defending yourself, then try to give the evidence. Respiratory depression. Lots of people develop respiratory depression even with a single dose of benzodiazepine, and some of the people won't develop it at all, and even then a mega doses. Behavioral disinhibition. Now this occurs with most of the drugs that we abuse. You talk about weed, you talk about marijuana, opium, alcohol, any. There is a behavioral disinhibition. वो आपकी जो रुकावटें हैं वो खत्म हो जाती हैं, वो बैरियर्स अपलिफ्ट हो जाते हैं और आप थोड़े से ओपन हो जाते हैं, डिसइनहिबिटेड हो जाते हैं. उसकी वजह से hostility, impulsive thefts, acts of aggression, verbal hostility, they are all seen, but not always, very rarely. Incontinence of urine. If they are too much sedation, then of course incontinence. Sexual dysfunction. Now decreased libido. एक शख्स जो गोली खा के सो रहा है उसकी libido तो वैसे ही खराब हो जाएगी. So what to talk about it? Inability to maintain an erection. Obviously, जब आप drowsy होंगे, आपकी सोच का महवर उस तरफ आएगा ही नहीं, तो आपकी erection maintain नहीं होगी. An emergence of depressive symptoms. Now these are all abusive potential. So again, I can talk for days on it, but there is complexity associated with it. The effects of benzodiazepine vary from person to person according to the age, general health, if other drugs are being taken at the same time, how much is taken, how it is taken, whether the drug has been taken before, and for how long. Even the food impacts the absorption and distribution of a benzodiazepine, and it can make the benzodiazepine have a variable effect on variable person. So खाने से कितनी देर पहले गोली खाई थी उसका इफेक्ट फर्क होगा खाली पेट, और खाने के साथ गोली खाई थी उसका इफेक्ट फर्क होगा क्योंकि वो मिक्स्ड हो जाएगी फैटी सब्सटेंस के साथ और उसकी एब्जॉर्प्शन डिफरेंट होगी और उसकी हाफ लाइफ पे भी इंपैक्ट आ जाएगा. So all of these things matter when you are giving a benzodiazepine. Keep that up. Immediate effects. Low to moderate doses, short-term use, less than 2 weeks of benzodiazepine may have the following effects: relaxation, calmness, relief from tension and anxiety temporarily. Other effects includes drowsiness. Now, as I told you earlier, that there is the phenomena of sedation and hypnosis are the continuum of the same process. So पहले sedative effect आता है जिसमें ये calming down effect आता है, बाद में hypnotic effect आता है जिसमें वो सो जाता है. So drowsiness से पहले calming down effect है. Tiredness, lethargy, dizziness, vertigo, blurred or double vision, slurred speech, stuttering, mild impairment of thought process and memory, feelings of isolation and emotional depression. All of these things do come if the dose is variable. अगर उसको sedative hypnotic effect के तौर पे दिया जा रहा है. Higher dosages, you have drowsiness, over sedation, and sleep. So sleep is a hypnotic effect of a benzodiazepine. So in low doses, it may act as a sedative, anxiolytic. In high dosage, the same drug will act as a hypnotic and sleep agent. Higher doses may also produce confusion, slurred speech, poor coordination, impaired judgment. अब इसमें एक छोटी सी और आपको रियल लाइफ सिचुएशन बताऊं और ये हकीकत बता रहा हूं कि अगर मेरा कोई पेशेंट 40 गोलियां पैरासिटामोल की खा के इमरजेंसी जाएगा तो मैं पैनिक कर जाऊंगा कि इसने 40 गोलियां खाई, बिकॉज 40 गोलियां पैरासिटामोल की would be dangerous to a person. रीनल शटडाउन हो सकता है, एक्यूट रीनल फेलियर हो सकता है और उसकी बहुत सारी कॉम्प्लिकेशंस हो सकती हैं. लेकिन अगर मेरा कोई पेशेंट 30 गोलियां ब्रोमाज़ेपाम की खा के गया है इमरजेंसी में तो मैं कहूँगा जी उन्होंने भी सौंड दियो, मैनू भी सौंड दियो, कुछ नहीं होगा, बिकॉज दे आर, इनका थेराप्यूटिक इंडेक्स बेंजोडाइज़ेपिन्स का बहुत बड़ा है. So they are safe drugs, not as dangerous as they are quoted in general. So you have to again assess the situation. Lots of factors playing the role. Again, why he took it, how much he took it, when he took it, what was the personality, how was he before that, how is he now? Only then you will decide. Blood flumazanil is a good option in front of you instead of washing the stomach and what the usual emergency people do. I don't believe in that. All you have to do is to get a flumazanil, give him the IV infusion of the flumazanil, and he'll be out and he'll be okay. That's the best answer to the problem. Very high doses of benzodiazepine can cause unconsciousness or coma. Death rarely occurs from overdose of a benzodiazepine alone. This sentence is important. Death rarely occurs from an overdose of a benzodiazepine alone, but some deaths have occurred when large doses are combined with alcohol or other drugs. So, as I said to you earlier, If my patient takes an overdosage of benzodiazepine, I will let him go off to sleep for maybe a day, 2 days, and then he'll be okay and he'll be fine if the vitals and other things are stable. So the use of benzodiazepines over a long period of time, more than 4 to 6 weeks, is not recommended. Benzodiazepine can help to relieve anxiety in short term, but they do not solve the problem that caused the anxiety in the first place. They treat the symptoms, but not the cause. Patients given benzodiazepine should be warned that the residual effects of these drugs may impair their ability to perform potentially hazardous activities as operating machinery or driving a car. But this is same with alcohol. This is same with any substance abuse, right? This is same even with some antipsychotics as well. The long-term use of benzodiazepine may cause drowsiness, nausea, lack of motivation, difficulty in clear thinking, blah blah blah. So ये सारे symptoms हो सकते हैं. ये फैज की एक है गजल है और ये इसके एक कता जो है वो मैं यूजुअली नहीं पढ़ता क्योंकि वो इतना दिल को लगता है कि उससे आपको वहशत होनी शुरू हो जाती. बट हकीकत पे है डिपेंडेंट, इसलिए थोड़ा सा पढ़ूंगा. मुझसे पहली सी मोहब्बत मेरे महबूब न मान, मैंने समझा था कि तू है तो दरख्शां है यार, तेरा गम है तो गम दहर का झगड़ा क्या है. तू जो मिल जाए तो तकदीर नुगू हो जाए, यूं ना था मैंने फकत चाहा था यूं हो जाए. अनगनत सदियों के तारीख बहीमाना तिलिस्म, रेशमो अतलस कम ख्वाब में बनवाए हुए, जा बजा बिकते हुए कूचा बाजार में जिस्म, खाक में लिथड़े हुए खून में नहाए हुए, जिस्म निकले हुए अमराज के तनूरों से, पीप बहती हुई गलते हुए नासूरों से, लौट जाती है उधर को भी नजर क्या कीजिए, अब भी दिलकश है तेरा हुस्न मगर क्या कीजिए, और भी दुख हैं जमाने में मोहब्बत के सिवा, राहतें और भी हैं वस्ल की राहत के सिवा. मुझसे पहली सी मोहब्बत मेरे महबूब न मान. Unfortunately, if we really see things, there are so many things other than love and affection which can hamper your lifespan, whole of your lifespan. So साइकाइट्री में हमें रोज ऐसी चीजें नजर आती हैं, हम देखते हैं और हम सुनते हैं और अनफॉर्चुनेटली हम महसूस भी करते हैं और हमें करना भी चाहिए. As a psychiatrist, we have to feel it here if we really want to help our patients. Benzodiazepine dependence. Prolonged use of benzodiazepines may lead to a psychological and or physical dependence, making it difficult to discontinue use. फिर इस लफ्ज पे गौर करें. Prolonged use of benzodiazepines may lead to a psychological and or physical dependence. So there is more psychological dependence than actually a physical dependence, making it difficult to discontinue. Dependence on the benzodiazepine affects a high percentage of patients suffering from anxiety disorder. These are common conditions which require prolonged treatment. And physiological dependence can cause withdrawal symptoms to emerge with a rapid dose reduction on abrupt discontinuation of the drug. So don't do it. Psychologically, long-term use of benzodiazepines may lead to over-reliance on the need for the agent, loss of self-confidence, and varying degrees of drug-seeking behavior. If I have a patient of a benzodiazepine abuse, I will first assess these things. Whether is he having loss of self-confidence, how much motivation is there, how much fearful he is that he will stop and he will develop some symptoms. I will treat those things. Anticipatory anxiety first, and then I will treat any other problem. So dosage escalation of 10 times the cycle of tolerance and dependence of the patients may have difficulty in discontinuing drug therapy. Ab therapeutic dosage of a diazepam is something between 60 to 80 milligrams per day. Now this says dosage escalation of 10 maintains the cycle. Dosage escalation often maintains the cycle of tolerance and dependence. अगर मैं पेशेंट को दवाई देता चला जाऊं 80 मिलीग्राम फॉर अ लॉन्गर पीरियड ऑफ टाइम, maybe 6 half lives, only then I will be able to see the dependence phenomena and difficult to withdraw. Otherwise, withdraw ho jayegi. There are ways to withdraw that. Maybe if I'll be having some time, I will talk about that as well. Chronic use of benzodiazepines, I'm not going into it. Probably we have sorted it out. Short-acting benzodiazepines are usually not recommended than the long-acting benzodiazepines. And lastly, long-acting benzodiazepine. Long-acting benzodiazepine are less likely to induce dependence. However, long-acting benzodiazepine accumulate in the body. Elderly and liver-impaired patients have a low capacity for benzodiazepine elimination with consequent drug accumulation and toxicity. Several benzodiazepine-related side effects such as drowsiness, sedation, lethargy, and impaired motor and cognitive functions are related to drug accumulation. I will go to international recommendation. Now, this is related to benzodiazepine. Dose. The lowest dose which can control the symptoms should be used. 1. Long-term chronic use is not recommended. 2. Treatment should always be tapered off gradually. 3. 4. Patients who have taken benzodiazepines for a long time may require a longer period during which the doses are reduced. 4. So this is generally the recommendation for a benzodiazepine thing. Final comment. Caution must be exercised with active or remote history of substance use or addiction. Compared with benzodiazepine, antidepressants have a longer onset of action but are the best agents for long-term treatment of anxiety disorders. Clinical judgment is based on the assessment of the risk versus the benefits of the therapy. And such an approach might take into account whether substance abuse is active or remote. And education, consultation, documentation will definitely improve the situation. Thank you very much everyone for listening to me. Okay, अभी मेरे पास कुछ मिनट है, सो ये चलते चलते एक नज़म फिर सुना दूं. चलो एक नज़म लिखते हैं, किसी के नाम करते हैं, मगर अब सोचना ये है कि इसमें जिक्र किसका हो, इसमें बात किसकी हो, इसमें ज़ात किसकी हो, और ये भी फर्ज करते हैं कि जिस पे नज़म लिखते हैं इससे मोहब्बत करते हैं. हमारे सारे जज्बों को बस इसकी ही जरूरत है, इजहार की खातिर एक नज्म की हाजत है. चलो एक काम करते हैं कि जो हम नज्म लिखते हैं तुम्हारे नाम करते हैं, तुम ही उन्वान हो इसका, तुम्हारा जिक्र है इसमें, तुम्हारी बात है इसमें, तुम्हारी जात है इसमें. As a psychiatrist, unfortunately, empathy, care, and other aspects of the biological theories of most of the psychiatric morbidity are or essential. So जब हम बायोसाइकोसोशल मॉडल ऑफ हेल्थ केयर की बात करते हैं तो हम ये भी बात करते हैं वो कहाँ रहता था, वो कैसा था, उसका फाइनेंशियल हालत कैसी है, उसके घर वाले कैसे हैं, उनका रवैया कैसा है, उसका एजुकेशनल स्टेटस कैसा है. एवरीथिंग मैटर्स, everything matters. Any question, I am willing to respond to it.
Yes, sir. एक क्वेश्चन है.
एक क्वेश्चन है, उसके बाद मिशी ने एक नज़म सुनानी है.
Oh wow, that's great.
पूछो.
अच्छा सर, अभी आप ड्यूरिंग प्रेजेंटेशन ही जिक्र कर रहे थे तो फिर मेरे जहन में ये क्वेश्चन आ रहा था कि हमारे पास यूजुअली ओपीडी में बहुत मेडिकल स्टूडेंट्स प्रेजेंट करते हैं ड्यूरिंग देयर एग्जाम सिचुएशन, स्पेसिफिकली जब उनका प्रॉफ होता है. तो जैसे आपने और मैंने देखा भी है कि उन्हें बेंजोडाइजेपिन्स जो हैं वो फॉर द टाइम बीइंग रिकमेंड की भी जाती हैं, या ऐसे ही अगर एग्जाम सिचुएशन ही कोई और ऐसा एक फॉर द टाइम बीइंग सिर्फ स्ट्रेसर है किसी भी मेरे पे या किसी पे भी, तो उसकी स्लीप डिस्टर्ब्ड है और वो एंशियस है, लेकिन वंस द स्ट्रेसर इज रिमूव तो चीजें सेटल हो जाती हैं. तो ऐसी सिचुएशन में हमें फिर क्या ड्रग देनी चाहिए इंस्टेड ऑफ बेंजोडाइजेपिन, स्पेसिफिकली डिस्टर्बेंसेस, ये प्लीज बताएं.